Pleasure to have here Professor Dave Singh from University of Manchester in the UK. Combination therapy in asthma is his topic. Dave?
Thank you. So I'm going to speak now about using combination therapy in patients with asthma. Here's my disclosures. So I'll start by just giving a very brief overview of the way that GINA sets out some excellent frameworks for us to treat asthma, and then show you what the problem is with using combination treatments in asthma. So we have the long-term goals of asthma management based around short-term symptom control, immediate symptom control, but then importantly, long-term risk reduction. We actually know a number of factors that lead to increased risk. It's all well documented. We have a number of factors that are risks for exacerbations, uncontrolled symptoms, low FEV1, incorrect inhaler technique. We have risk factors for chronic airflow limitation, no inhaled steroid treatment, smoking, mucus hypersecretion, etc. So we know all this. We also have an excellent framework in how to treat our patients. We establish a dialogue, a relationship between the doctor and patient, so we understand what the patient wants and can do. And then we have this way of adjusting treatment. Now that's something I'll come back to. Stepping treatment up and down, assess, adjust, and then review. And in terms of the doctor-patient relationship, we have very clear guidance on the type of things we should be doing with patients, inhaler skills, checking their adherence, management plans. So this is all great. We have a framework, we know what we're doing. So here's the problem. Patients don't take their medicines. So we have combination treatments, and half the patients will freely admit that they do not take their medicines every day. So that's the first problem. So if you put patients in a clinical trial and you make sure that they're compliant, and you use the most well-known combination that we have in asthma, inhaled steroid plus a beta agonist, what happens? Well, this is the goal study, and throughout the year of the study, there was a proportion, about 30 to 40%, who never achieved a single week with well-controlled asthma. So there's always two ways of looking at these graphs. One is to say, oh look, 70% of patients with the combination achieved at least one well-controlled asthma week. Then the other way is to say 30% of patients never achieved it, even if you made sure in a clinical trial that they took their medicine. So what does GINA say that we could do with our compliant patients if they're taking an inhaled steroid beta agonist combination? So for patients already on a combination, what can we do next? So we're talking here about step 4-5 patients, which the definition is now simplified. These are severe asthma patients. We need to step them up in therapy, and what could we do? So that's what I'm going to deal with in the rest of the lecture. Combination therapy adding on to inhaled steroid beta agonist. And one of the medicines that's slipped in now is the use of tiotropium, a long-acting antimuscarinic. So what's the evidence for this? So there's 4 studies that were done for regulatory purposes. The numbers of these studies are 416, 417, 418, 419. So I'll show you the first two, 416 and 417. And this is tiotropium added on to ICS-LABA. A single dose of tiotropium here, 5 micrograms. Now on the surface, when you look at that graph, it's very straightforward that there's a reduction in exacerbations in patients who are poorly controlled on inhaled steroid beta agonist. However, there is some complexity here. I'll show you the characteristics of the patients in these 4 studies. What you've just seen is the pooled results of 416 and 417. There was an inclusion criteria that I don't understand why it was there, and if any of you know, please tell me afterwards. It was that patients were required to have an FEV1 FVC ratio of less than 0.7 after short-acting bronchodilator, after salbutamol. Now that's more of a COPD diagnostic criteria, but this is an asthma study. So consequently, if you look at the FEV1 FVC ratio in 416 and 417, it's 0.6. And the patients are older, and there's more ex-smokers, and their reversibility is less. So it's a different population, maybe, definitely, to what you see in standard asthma trials. Now 418 and 419, I'll show you the pooled data now. That was done on top of inhaled steroid alone. And there's a comparator arm, the beta agonist salmeterol. And this is the change in lung function at the end of the study for salmeterol, and then 2 doses of the LAMA here. 5 micrograms that we're used to giving in COPD and that was used in the previous study, and then 2.5 micrograms. Because the regulators always say you need to show that the dose you want to use is the optimal dose. Now, perhaps surprisingly, the biggest effect on lung function was with the 2.5 microgram dose. And interestingly, salmeterol actually fared worse out of all the bronchodilators here. Now this, to me, is a slightly unexpected result, because I would have expected 5 micrograms to be at least as good as 2.5 micrograms, if not better. So I've cut and pasted some text from the FDA evaluation, which is published in the Annals of the American Thoracic Society. Nice article which goes through the results of these 4 studies. And they identify that the inclusion criteria 416 and 417 was different. And then they use this marvelous phrase that you're going to hear about in a short while, that the characteristics perhaps were more of patients with asthma COPD overlap syndrome than typical asthma. And they say that in their opinion, the appropriate dose for asthma is 2.5 micrograms, whereas the appropriate dose for COPD is 5 micrograms. Now, they put forward some reasons as to why the effects could be different in asthma and COPD, just speculation really. And then they say for patients who have ACOS, and that's very poorly defined, you could use either dose. So we don't really know how to use LAMAs in asthma. We don't have clear guidance, but the evidence is not there. So here are some of the questions. Companies are making fixed triple combinations, ICS plus LABA, and then a LAMA as well. And they're developing them for COPD, and they're developing them for asthma. So what do we do with these? Do we take the approach that we've done for ICS LABA and say, so for patients on inhaled steroids, by and large, if they're poorly controlled, we lump them all together and everybody steps up to ICS LABA? Do we do the same for these triple therapies in asthma? Does everybody who's at step 4 then get another bronchodilator, a LAMA? And then if you do that and you gain control, do you step down? An evidence-free zone? That's a question. And then there's which dose? So if you're using tiotropium as part of a free combination, I think that's not clear. So what are the alternatives, or what could you use on top of triple therapy in the future? Well, we have the emerging biologics. And the one that we're going to be confronted with soon, now, is anti-IL-5 therapy. And going back about 7 years, we had data emerging that using sputum eosinophils could select a subgroup of patients who would respond to this anti-eosinophil therapy. So whereas with inhaled therapies, we very much lump all the patients together in terms of combination and say they could all receive this, the additional combination with a monoclonal antibody is going to be for subgroups of patients. So that's a difference. But sputum eosinophils are not a practical thing that every physician is going to do. How do we take this forward? Well, we're going to have to find practical ways of selecting subgroups of patients for anti-IL-5 and for the other biologics. Now, initially, we thought clinical phenotyping would be a great idea. You could take clinical measurements, subdivide all the patients, and have groups that would receive different biologics. And then you end up with this sort of thing. Great study, excellent paper, usable in clinical practice? No. The reasons for this, if you look at different phenotyping studies, you never get the same result. You never get the same result because people measure different things. And when you measure different clinical parameters, you end up with different groupings. And even if you could harmonise your clinical parameter and get the same groupings, there's still a problem because these biologics target specific mechanisms. And the same mechanisms, different mechanisms can give rise to the same clinical phenotypes. So in terms of selecting biologics, we need to move from phenotypes to endotypes. And an endotype definition is based on a mechanism. These biologics will target mechanisms. And if we can develop biomarkers that are specific for those mechanisms, so you know that that mechanism is present and overactive in that patient, you then have a better way of selective treatment with a better chance of increased effectiveness and perhaps minimize risk. And to clarify this in terms of the relationship between endotypes and clinical phenotypes are what you recognize in terms of clinical features and clinical measurements. Endotypes, mechanisms, make up the clinical phenotypes. And often patients have multiple endotypes making up their clinical phenotype. And you may need to have multiple medications that target the multiple endotypes that patients have. So a brief review of where we are with biomarkers that could be used to select these monoclonals. This is what we are going to use in future, predominantly. Blood eosinophil measurements, not sputum eosinophils, periostin measurements from blood, and exhaled nitric oxide. Now, blood eosinophils they're associated with sputum and lung eosinophil levels. And because of that, there are trials now that show that blood eosinophils can be used to select patients who will respond to anti-IL-5 therapy. The controversy, the thing we're not sure about, is what the best level, what the optimal level to select is. And I think some of those discussions will be more to do with cost effectiveness. Periostin was established as a biomarker on the basis of experiments done with lung epithelial cells stimulated with IL-13 in the presence and absence of steroid. And periostin is a steroid-resistant protein released from epithelial cells stimulated with IL-13. So you can make the extrapolation that patients who have steroid-resistant IL-13 production will have high periostin levels, And we see in this study with anti-IL-13, it's the periostin high subjects who have the biggest response. Now, anti-IL-13 is involved in T2 type inflammation. Eosinophils are involved in T2 inflammation. So unsurprisingly, there's an overlap. Patients with higher periostin have higher eosinophil levels. So that's one of the other problems we're going to have, that although we would like to discretely target these groups, there is an overlap because these monoclonal antibodies are targeting patients who have broadly, you could say, some similarities in their type of inflammation. Now, blood eosinophils remain the best predictor of airway eosinophilic inflammation, more so than periostin. Where does nitric oxide fit in? Nitric oxide, again, is actually a predictor of IL-13 responsive patients, but it's the only biomarker out of those that I've shown you that can also monitor response. So if you're using IL-13 and it's successful, the nitric oxide level will go down. So here's a brief summary of the usefulness of the biomarkers in the future for these monoclonal antibodies. For anti-IL-5, blood eosinophils will be the measurement. For anti-IL-13, periostin or nitric oxide can be used. And for anti-IL-13, nitric oxide can be used to monitor response. Now, having talked a lot about T2 inflammation, the missing gap for monoclonal antibody treatment is actually non-T2 inflammation. So we've got this crowded space for T2 or Th2, whatever you want to call it, and then this empty space for the other type of inflammation that a lot of severe asthma patients have. So my conclusion, what we do now with combination treatment in asthma, with inhaled steroid and beta agonist, is we more or less lump all the patients together, and they all get that combination. But now we're going to have triple combination, and we already have the option to give a LAMA as a free combination. And there are questions there. Do we lump all the patients together, or do we split them out? And are there certain patients who would do better with a LAMA? But in the future, for biologics, that's definitely a case of splitting the patients out. But the patient selection and the use of the biomarkers, we've yet to refine for the optimal use in clinical practice. Thank you for your attention.
Thank you, Dave. Question from the audience. Helgo.
Thank you very much. Why you do not mention IgE as a biomarker?
Yes, yeah, I could have talked about that. It's just a question of time. So that could easily have been added in there.
That's very important.
It is very important.
Differentiate.
Yeah. So obviously there is a subgroup of patients who will respond there. So as you mentioned it, one of the problems with IgE is that there's probably a subset of patients who have high lung IgE levels, but without having higher blood levels of IgE. And one of the problems we have now with anti-IgE therapy is that we might be missing that subgroup of patients.
Now, thank you very much, Dave, for doing a very practical, using a very practical approach to the presentation. I tried to go a little further. Now, with the best combination, and it goes also a little bit on the next speaker, but it's to you. With the best combination therapy, you reduce one exacerbation every 4 years, 25% in COPD, maybe a little bit more in asthma, particularly I'm talking about moderate severe asthma. And in COPD, I mean, there is evidence that the exacerbations have quite significant impact on mortality and other solid outcomes. In asthma, do we have these, and do we recommend continuous treatment to reduce of this amount the exacerbation with the understanding that they do not have major, and correct me if I'm wrong, impact on heart outcomes like mortality or hospitalization.
Oh, so to go a little bit deeper then, the combination ITS-LABA for asthma targets very preferentially the T2 profile. So if you look at Prescott-Woodruff's study, where he subdivided patients back in 2010, I think it's in the Blue Journal, he subdivided the patients based on T2 biomarkers, then he randomized, then everybody got for 6 weeks inhaled steroid or placebo. And the patients who did not have T2 biomarkers, they had no FEV1 response. Now, using FEV1 as a surrogate for exacerbations, etc. So although we lump everybody together, and they all get inhaled steroids beta agonists, there's a certain group who actually you're giving inhaled steroids and they don't have the profile of inflammation that would even respond. So I think your question then, we need to divide the patients up, and the answer will be different for these two types of patients. The exacerbation rate reduction will be very good in the T2 profile patients, but not in the non-T2. Now, in the T2 patients, there's a subgroup who, even despite inhaled steroids, have excessive T2 inflammation, and that's where we use monoclonal antibodies. But for the other group, the therapeutic index of the combination we use at the moment, very, very poor.
Yes, severe patient.
Yeah.
Sergio Bonini.
My question refers to the second issue of your conclusion, on which I fully agree, that the selection of biomarkers has to be optimized. I have recently reviewed the 3 studies which brought to the approval of mepolizumab by the European Medicine Agency. And if you look at the threshold of eosinophils that can be considered useful for selection of patients, this is very confusing, and threshold is very low. So that the conclusion of the CHMP was to leave to the doctor to take a decision about what is the threshold of eosinophils, and this does not help. Can you say for the biomarkers that you have indicated, what threshold should be considered as relevant for selection of patients with different treatments?
Yeah, sure. So for eosinophils, I made a loose reference to cost effectiveness. So there's no doubt that as you move the eosinophil threshold higher, the benefit gets bigger. So when you use a threshold of 0.3 or 300s, whatever units you want to talk about, for eosinophils, then the effect size on exacerbations moves nearer to 30 or 40%, not only for the compound you're talking about, but also for resluzumab. So I personally think that's where we're going to end up, because for cost effectiveness, the trials have used 150, and I think the effect size is too low. But if you read, I mean, you've read it, if you look at the sub-analysis, where you use 300, the effect size goes up to 30 or 40%. So I think you need to do the cost effectiveness analysis, and I think that's where it will end up. Now, for periostin, I think we have less guidance and less evidence. And then we have the problem of standardization of the biomarker, because at the moment, the different periostin kits are not standardized together. Maybe in the future, we'll actually be using a panel, because there's overlap between eosinophils and periostin. So, and then what the cost of these will be important as well. So, for example, if you are eosinophil high, periostin low, that will guide you to an anti-IL-5 therapy. If you are eosinophil high, periostin high, you might go on cost.
Okay. Last, very short.
Yeah.
Yes, I'd like to go back to the tiotropium study in which you said produced the unexpected result in terms of the dose. What kind of explanation have been done to this, and other kind of study design like a case crossover would be worthwhile?
Yeah, so in that article I quoted, the FDA evaluation, they speculate, so I use the word speculate because there's no evidence for this, that in patients with asthma, the higher doses of the anticholinergic cause some drying of the airways, and that in some way reduce the therapeutic effect. Now, that's not my opinion, that's just what's written in there. Right? You do occasionally see it, that you get bell-shaped dose-response curves in pharmacology, and at the higher doses, sometimes you get receptor saturation and internalization. Now, we have no evidence for that type of mechanisms here. You certainly see that with neutrophils. So there's a lot of neutrophil biology that when you go too high, the dose-response curve becomes bell-shaped. Why that would happen in asthma and not COPD, I don't know. So it could be a chance finding.
Thank you.
Could be a chance.
Thank you very much.
Thank you.